Hi everyone, good afternoon. This is Dr. Ina Irabon, and my task for today is to discuss with you the role of immunologic treatment in RPL. So this is the outline of my lecture. I first discuss the immunologic mechanisms in both the normal pregnancy and patients with RPL, and then I go on to discuss the different immunotherapeutic options. However, because of time constraints, I will just focus on treatments that directly target immune factors or interactions such as allogeneic, lymphocyte immunization, intravenous immunoglobulin, intralipid, and prednisone. I would no longer tackle heparin, aspirin, and progesterone, although we all know that these treatments have immunomodulatory properties. Now, these treatments also have been extensively reviewed in so many literature. A large proportion of unexplained RPL may be due to immunologic causes, and immune-mediated pregnancy loss is characterized by either autoimmune or alloimmune disturbances. In autoimmune abortions, the development of the placenta and the embryo is affected by maternal autoantibodies and autoreactive cells, such as in APAS, which target decidual and trophoblastic molecules. Now, in alloimmune pregnancy loss, the impaired maternal immune system reacts against the semi-allogeneic embryo and damages the trophoblast through allogeneic rejection type reactions. Now, clinically, the two categories cannot be, or it's very hard to distinguish these two categories as both represent a broad immunological imbalance that leads to pregnancy loss. Now, in order for us to understand the rationale behind these immunologic treatments, we must first take a look at the endometrium in the non-pregnant state and the decidua during embryo implantation and decidua of a patient with RPL. So this is what an endometrium in the non-pregnant state looks like. So we see here that the endometrium is home to a vast array of immune cells. Included here would be the macrophages of the M2 type and the uterine NK cells. And both of these cells belong to the innate immune system. So you can see that both the macrophages and the uterine NK cells are situated very near the endometrial glands and the spiral arteries. We also see here dendritic cells, neutrophils, and so on and so forth. So now we take a look or a closer look at the decidua during embryo implantation. And as you can see here, there is a dramatic increase in the immune cells, so much so that the trophoblast of the implanting embryo is like bathing in a sea of cytokines or in a sea of immune cells. And as we all know, the maternal immune system undergoes considerable modulation to establish an immunologically favorable environment for the fetus. Now, these macrophages and the uterine NK cells are situated very near the trophoblasts and the spiral arteries, suggesting that they play an important role in spiral artery remodeling, and trophoblast invasion. The decidual NK cells also have specific receptors for the human leukocyte antigens of the trophoblast cells. These are uniquely expressed actually by the trophoblast cells. And as you can see here, we have the killer immunoglobulin receptor, which targets the HLA-C, the ILT2 receptor, which targets the human leukocyte antigen G, and the CD94 NKG2A receptor, which targets the human leukocyte antigen E. Now, this interaction between the uterine natural killer cell and the human leukocyte antigen actually plays a key factor in the prevention of the maternal immune rejection of the conceptus. And add to that, no, the this galactine or this ligand galactine 9 binds to the uterine NK cell or the decidual NK cell, which leads to an increased production of the anti-inflammatory cytokines TGF, beta, interleukin 4, interleukin 10, and a decrease in the production of pro-inflammatory cytokine TNF alpha. The dendritic cell also play a very important role as this contributes to the generation of T regulatory cells. Now, T regulatory cells are very important cells because they are contribute to maternal immune tolerance and anti-inflammation. Now, all of these changes in the immune system of a normal pregnancy shifts the Th1, Th2 equilibrium to a Th2 dominance. Now, with Th2 dominance, there is an increase in the production of anti-inflammatory cytokines IL-4, IL-5, IL-10, and IL-13. This Th2 response facilitates the blockage of cytotoxic reactions, thereby creating an intrauterine environment that is conducive for embryonic growth and development. Now, what happens in the decidua of a patient with recurrent pregnancy loss? Now, as you can see here, we have dysfunctional uterine NK cells and dysfunctional T regulatory cells. Actually, what happens here is that there is a decrease in the CD56 bright, CD16 negative NK subset, as well as an increase in the number of the CD56 plus CD16 positive NK subset. We also have a substantial decrease in the levels of T regulatory cells. Now, all of these changes contribute to maternal immune rejection of the trophoblast and a defective vascular remodeling. As I've already mentioned a while back, uterine NK cells play an important role in spiral artery remodeling. Now, the decrease in the T regulatory cells is actually paralleled by an increase in the Th17 cells. Now, this defect in the immune response leads to a shift in the Th1, Th2 equilibrium, leading to a Th1 predominance in a patient with recurrent pregnancy loss. Now, this Th1 predominance creates an increase in the levels of the pro-inflammatory cytokines, which are the TNF alpha, interleukin 2, and interferon gamma. Now, this Th1 response leads to fetal rejection. Now, this is a very, very nice, beautiful table showing to us the difference in the immunologic milieu of a patient with normal pregnancy versus a patient with recurrent pregnancy loss. And as you can see here, a patient with normal pregnancy has very high levels of Th2, very high levels of T regulatory cells, low levels of Th1, and low levels of Th17. Now, all of these create Th2 predominance, which increases the production of anti-inflammatory cytokines. Now, contrast that with what is happening in a patient with recurrent pregnancy loss. So, in a patient with RPL, the Th1 levels is very high, Th17 levels very high, and they have very low levels of Th2 and T regulatory cells, thereby creating a Th2 or Th1 predominance that increases the levels of the pro-inflammatory cytokines. Now, because of the discovery of immunological abnormalities in RPL patients, several immunomodulatory therapies were introduced to maintain the immune balance at the maternal-fetal interface. Now, within this context, immunotherapy may be considered as one of the treatment options to improve pregnancy outcomes in these women. Now, these are the following that's listed here. Now, because of time constraints, I will just focus on the first four immunotherapy options. Now let's first talk about lymphocyte immunotherapy. Lymphocyte immunotherapy is actually active immunization, either using lymphocytes from the partner of the patient or from a third-party donor. These treatments have been suggested to improve the immunological recognition by establishing microchimerism, modifying cytokine production, dampening NK cell activity, and producing anti-paternal or blocking antibodies. Now, this is a very, very nice diagram showing to us the possible mechanism by which LIT enhances pregnancy rates in women with RPL. So, LIT actually induces the production of anti-paternal cytotoxic antibodies, mixed lymphocyte reaction blocking antibodies, and anti-idiotypic antibodies. Now, these antibodies actually cover the paternal human leukocyte antigen in the surface of the fetus and thereby prevent from maternal natural killer and T cells attacking. Furthermore, LIT also reduces T helper 1 and T helper 17 and increases levels of Th2 and T regulatory cells. Now, these changes leads to an increase in the levels of anti-inflammatory cytokines IL-10, IL-4, and TGF-beta, and decrease in the pro-inflammatory cytokines TNF-alpha and interferon gamma. Now, just to give you an idea how this is done, no, in LIT, the partner's blood is drawn. Then the lymphocytes are then separated from the whole blood by centrifugation and immersed in a saline solution after several washes. Now, the product will be injected intracutaneously on the patient's forearm. Then 4 to 6 weeks after the immunization, paternal anti-HLA antibody test can be performed. If antibodies are detected, then the couple can be advised to begin planning or try to get pregnant within 12 months. Otherwise, immunization can be performed again. Now, LIT is supposed to strengthen the mother's immune system against the paternal antigens that are present in the trophoblast. Therefore, the production of anti-paternal antibodies indicates the success of immunization. Now, what is the current scientific evidence that can support LIT as a treatment for recurrent pregnancy loss? Let us first look at this first study. This is actually a Cochrane systematic review and meta-analysis that is published by Wong et al. In 2014, and this includes 20 RCTs. Okay, as you can see in this forest plot, that there's actually no significant difference in the live birth rates between the group of patients that were given paternal lymphocyte immunization versus the group that was given placebo treatment. And this is also the same result seen, no improvement in the live births for patients given donor white cell immunization. However, critics of this paper, this Cochrane meta-analysis, have said that this is actually not a very good meta-analysis, since the authors of this meta-analysis included this study by Ober, okay, which in this study included only patients with 5 or more miscarriages and used a suboptimal dose of LIT, which is stored at 4 degrees centigrade for up to 3 days. Now, experts believe that LIT would be more beneficial if given as a fresh lymphocyte immunization and not the stored lymphocytes. Now, and because of this, they now prefer other meta-analysis on LIT, no other than this Cochrane meta-analysis. So included in the studies will be this meta-analysis by Clark et al. That was published in 2001. And as you can see here, that there is a significant increase in the live birth rates for patients who were given immunotherapy. Now, this paper by Clark et al. In 2001 concluded or recommended that allogeneic leukocyte immunotherapy using freshly prepared blood mononuclear leukocytes may be beneficial for a subset of women having recurrent clinical miscarriages of normal karyotype embryos beginning after 6 weeks gestation who have no evidence of autoimmunity. And patients who become pregnant more than 3 months from the time of primary immunization should be considered for boosting prior to 6 weeks gestation. However, they also concluded that randomized trials of alternative treatments or alternative treatment strategies are also needed. Now, how about the evidence for LIT given before pregnancy or before and during pregnancy? Now, this is answered by a meta-analysis that is done by the group of Liu et al. Published in 2016. Now, LIT that is performed only before pregnancy can improve live birth rates in women with RPL with an odds ratio of 2. Okay. However, if immunotherapy is performed before and during pregnancy, then it significantly improved the live birth rate with an odds ratio of 4.67. Okay, so it means that it's better to give the LIT before and during pregnancy rather than just before pregnancy, although both strategies produced an increase in the live birth rates. Now, how about the role of LIT in primary and secondary RPL patients undergoing IVF. Okay, so this is answered by this meta-analysis done by by the group of Achille et al. That was published in 2018. And as we can see here, there is no difference in the live birth rates between the patients who were given LIT versus the control. And this is for primary RPL patients. And we have a similar result for secondary RPL patients. There's no difference in the live birth rates for secondary RPL patients given LIT versus the control. And these are patients for IVF. So the conclusion of this study is that the role of immunotherapy or the immunotherapy has no role in improving the live birth rate in women undergoing IVF treatment or in the prevention of recurrent pregnancy loss. And currently, immunotherapy should be used only in the context of research and should not be used in routine clinical practice to improve reproductive outcomes. Now we go to intravenous immunoglobulin. IVIG is a fractionated blood product prepared from the serum of between 1,000 and 15,000 donors per batch. Maybe this is the reason why IVIG is very, very expensive. Now, high-dose IVIG is used as an immunomodulatory agent in immune and inflammatory disorders. IVIG has been shown to depress the killing activity of peripheral blood NK cells. It also has significant inhibition of the production of the pro-inflammatory cytokines and also enhances the proportion of cells producing anti-inflammatory cytokines. Now let's see at the current scientific evidence we have regarding the use of IVIG as treatment for RPL. So let's first take a look at this meta-analysis done by the group of Hutton et al. That was published in 2007. And as you can see here, they identified 8 trials involving 442 women that were given IVIG therapy. And overall, as you can see here, IVIG did not significantly increase the odds ratio of live birth when compared with placebo for treatment of recurrent pregnancy loss. There is, however, a significant increase in the live birth rates following IVIG use in women with secondary recurrent miscarriage. Now, trials were also stratified according to whether therapy in patients was begun prior to pregnancy or following the achievement of pregnancy. And as you can see here, in the 5 studies beginning treatment after conception, IVIG did not produce significantly improved live birth rate compared with placebo. Now, in these 2 studies that started therapy prior to conception, women receiving IVIG had an increased live birth rate. Now let's take a look again at that Cochrane systematic review and meta-analysis by Wong et al. In 2014. Now this forest plot shows us that there is actually no significant difference in the live birth rate of patients who were given IVIG versus those patients who were given a placebo treatment. Now, is there a role of IVIG in RPL patients undergoing IVF? Now, this again is answered by the meta-analysis that was done by the group of Achille et al. And they showed that there's actually no difference in the live births between the group of patients who were given IVIG and the control group. Now, how about IVIG versus aspirin plus heparin for patients with APAS? As you can see here in this table, pregnancy outcomes, no? The women who received low molecular weight heparin plus low dose aspirin had actually higher percentage of live births compared to those who were given IVIG. And the patients who were given aspirin plus heparin for APAS actually had lower miscarriages or first trimester miscarriages compared to the group of patients who were given IVIG. Next, we talk about lipid emulsion therapy. Now, lipid emulsion therapy is actually more commonly known by its brand name Intralipid, and this is a fat emulsion containing soybean oil, glycerin, and egg phospholipids, and they are used intravenously as part of the parenteral nutrition in patients unable to tolerate an oral diet. And the main components are polyunsaturated fatty acids like linoleic, alpha-linolenic, oleic, palmitic, and stearic acid. Fatty acids actually have been shown to affect NK cell activity through peroxisome proliferator activated receptors, G protein coupled receptors, and CD1 receptors. Now, these mechanisms may be relevant in RPL, but of course, further testing is necessary. Now, what is the current evidence supporting the use of lipid emulsion therapy for the treatment of recurrent pregnancy loss? So as we can see here, this is a retrospective cohort study involving 127 patients. And we can see here that there's actually no difference in the clinical pregnancy rates and the live birth rates between the group of patients that were given intralipid and the control. And the conclusion for this study is that intralipid does not improve live birth rates and is not a cost-effective intervention in patients with RPL. And intralipid should not be routinely offered to these patient populations. Now, this is a meta-analysis done by the group of Komar et al. And published very recently this year. So they identified 9 studies reporting clinical pregnancy rate as an outcome measure. And as you can see here, there's a significant improvement in clinical pregnancy rate with the use of lipid emulsion therapy versus the group with that was not given immunotherapy. And when they removed all the cohort studies, only 4 RCTs remained, and the outcomes are very similar to this forest plot, where they see a statistically significant improvement in the clinical pregnancy rate, even with just the RCTs remaining. Now, in terms of miscarriage rates, there is a significant decrease in the miscarriage rates for patients who were given intralipid therapy versus the patients or the group of patients who were not given immunotherapy. How about evidence supporting the use of uh, lipid emulsion therapy versus IVIG? As you can see in this study by Kumar et al., that there's actually no difference in the live birth rates between the group of patients who were given intralipid therapy versus the group of patients who were given IVIG. And lastly, we talk about prednisone. Prednisone reduces the rate of miscarriage due to various reproductive immunological problems by increasing the T regulatory cells, which in turn regulate the peripheral NK cells and their homing into the decidua. They also suppress the peripheral cytotoxic CD16 levels. There is actually an ongoing clinical trial entitled Low Dose Prednisone Therapy in Women with Recurrent Pregnancy Loss, and this is expected to be completed by October 2021. So we await the results of this clinical trial. So meanwhile, we look at other evidences or published literature on the use of prednisone, including this study by the group of Gomaa et al., which looked into the effects of treatment with heparin plus aspirin versus heparin plus aspirin plus prednisone for patients with RPL. And as you can see here, no, in this table, the group 1 is the group that was given an additional prednisone. So those patients who were given additional prednisone had higher ongoing pregnancy beyond 20 weeks AOG as compared to the group that was not given prednisone. And the group that was given prednisone had actually lower miscarriage rates compared to the group that was not given prednisone. And what's really very nice about this study by the group of Gomaa is that they look into the actual levels of CD16 and CD56. So you can see here, there is a significant decrease in the levels of CD16 from baseline and then after treatment, but there's no difference in the levels of CD56. So this is a study comparing prednisone versus placebo for RPL patients with elevated uterine NK cells. And as you can see here, there is actually no difference in the live birth rates between the groups of patients who were given prednisolone and the patients who were given placebo. And also there's no difference in the miscarriage rates. Now let's look at some of the recommendations of international societies regarding immunotherapy. So let's first take a look at the ESHO recommendations on recurrent pregnancy loss, specifically on immunotherapy. So ESHO recommends this. No, lymphocyte immunization therapy should not be used as treatment for unexplained RPL as it has no significant effect and there may be serious adverse effects. ESHRE also recommends against the use of IVIG as a treatment of RPL. They also recommends against the use of glucocorticoids as treatment of unexplained RPL. It also ESHRE also says that there's insufficient evidence to recommend intralipid therapy for improving live birth rates in patients with unexplained RPL. So we also look at RCOG recommendations, and RCOG states that paternal cell immunization, third-party donor leukocytes, trophoblast membranes, and intravenous immunoglobulin in women with previous unexplained recurrent miscarriage do not improve live birth rates. Then similar recommendations by the ASRM. Uh, the ASRM does not recommend the use of lymphocyte immunotherapy and IVIG for women with unexplained recurrent miscarriage. So, in summary, paternal immunization, IVIG, intralipid, and prednisone all have been shown in some studies to have some beneficial effects in some RPL or in selected RPL patients with a poor prognosis and when used appropriately. However, results are inconsistent across studies. The results have been confounded by including a large number of inappropriate patients in trials, the lack of a standardized diagnostic criteria for specific immunological conditions, paucity of good quality RCTs, heterogeneity, and low sample sizes. Now, more research has to be performed to accurately determine the immune biomarkers that indicate which patients may benefit or actually benefit from immunologic treatment. So that's it for my lecture. Thank you for your kind attention.